I am very happy to be invited, and thank you very much for inviting me. I've trained medicine in Leicester, and I have a lot of love for Leicester, and I still have got quite a lot of friends in Leicester. Leicester has changed a lot in the last decade or so, or 2 decades or so, since I left Leicester. So diabetes is common, and it's very common in South Asians like you and I. I can see majority of the audience is South Asian, as is often the case when you speak to an audience that's predominantly based in Leicester and from other big suburban cities. And because it's common, we see a lot of kidney disease as a consequence. And of all the sort of complications that diabetes can lead to, in some ways, kidney disease of the severity side of things, of the ones that are more serious, kidney disease is probably the commonest complication of diabetes. So I'm probably talking to a lot of individuals who are diabetic themselves, and I think I don't need to sort of preach to the converted, but I think the commonest clues that might say that you may or may not have kidney disease is based on how long you've had diabetes. So longer you've been managed with diabetes, the more likely that you may develop kidney disease. Then I suppose the other big factor is how well is your diabetes controlled. And if your diabetes over the years are not well controlled, and I can assure you it's not easy because that involves a lot of time and attention, diet, lifestyle, etc. And if your diabetes is not well controlled, then there is a chance you may develop kidney disease.
Diabetes no awareness.
So the third clue is how what kind of other complications you've had. So the commonest other complication a lot of diabetics encounter is eye disease. That is why your GP will send you for an annual screening, which you call the retinal screening once a year. And if you have changes in the back of the eyes that are related to diabetes, then there is a high chance you also have kidney disease, because the same issues that's happening in the back of the eyes can happen inside your kidneys. So it is absolutely vital, and this is something that GPs will be doing on an annual basis. Every year, you need to have your kidney function checked. Every year, you need to have your urine checked for protein, because the earliest sign of diabetic kidney disease, even before it has an impact, before it affects your kidney function, is actually seeing albumin, protein, in your urine. Now, I describe the kidney as we all love cooking, so it's like a colander, right? And colander has lots of tiny holes, and you put your vegetables in, and the water and all the junk comes out of the holes. So a kidney has lots of these tiny, tiny holes that the fancy term is glomeruli. And what happens with diabetes, when it is badly controlled and you've had it for a long time, is that it tends to damage those holes. And therefore, things that shouldn't escape through those holes, and one of them is albumin, it's protein, it's in your blood, it's in the whole of your body, goes out of that. And that's your first clue. So it's important you keep those appointments that GP sends you, because that is a sign of, that's the first earliest sign that your kidneys might be affected. Now, just because you have protein in your urine doesn't mean your kidneys are damaged, or doesn't mean that your kidneys are not working. It takes a long time from seeing protein before there is permanent damage to your kidneys that cause what we call chronic kidney disease. So what is chronic kidney disease? That is when your kidney function isn't normal. What is normal kidney function? It's when your GFR test, that's how we measure kidney function, is above 60 mils per minute. Normally should be around 90. Once it falls below 60% mils per minute, which roughly is around 60% of your kidney function, that is when your GP, your doctor will start saying, okay, you've got chronic kidney disease, and then they stage it. There can be stage 3, which is a kidney function between 30 and 60%. Stage 4, when your kidney function is between 15 and 30%, and stage 5, when your actual kidney function is really bad, and then you're starting to think about dialysis, you're starting to think about transplant. So it's important to make those appointments, keep those appointments, and have those conversations with your doctor about your kidneys. Now, just because you have diabetes doesn't mean you're going to develop kidney disease. There's a lot of things that have happened over the years. And certainly when I became a medical student in 1989, and when I came out in 1995, there was very little we knew that we can do to make a difference. It's a whole new ball game now. Now, I think as a kidney doctor, it will be a failure on my part if one of my patients who come early with kidney disease ending up on dialysis or ending up on transplantation, needing a transplant, I have failed my job, because there's so much we as doctors and you as patients get together can do to change that, to prevent that happening. So I guess the first and foremost thing is around diabetic control. Now, and the second big thing is blood pressure, and they go along close together. And the thing that will make a big impact before medications, before tablets, anything, is indeed lifestyle. So what I think it's important to look at your diet, and it's important to look at how much exercise we get on a regular basis. It's not easy. I think here it's like 6 degrees Celsius. I think Leicester is a bit cooler. It's not easy to do exercise, but it's important to look at how much physical activity does. There are various electronic gadgets you can wear on your wrist to do steps and step counts. And I think that's something I always recommend. The other aspect is diet, looking at obviously carbohydrate intake. And I think you might have had conversations around diet and how much, it's not just sugar that is sweet, but it's also the hidden sugars that comes in rice, chapatis, any form of carbohydrates that you may be eating. The other big elephant in the room in our diets that is not helpful is the salt intake. So what we are allowed is around 5 grams of salt. I don't know what anybody knows what 5 grams means. That's 1 teaspoon. That is all, right? That is all the salt we should be having. And in fact, I would recommend if you're diabetic, you should have even less. And so again, you need to look at your diet. You look at what's the hidden salts, the seasoning. I work in Whitechapel, and one of the commonest seasoning products that's available is a company called Shan that makes various biryani mixes and curry mixes. That is salt in anything but I'm not here to put Shan into bankruptcy, but that is very rich in salt. And I think these are kind of things for a special day maybe, but not on a regular basis. So exercise, looking at your diet, mainly your salt intake and also your sugar intake. The next aspects are related to blood pressure. So certainly lifestyle will help to improve your blood pressure. And I can give you a truckload of medicines, but if you don't change your lifestyle, it's hard to control blood pressure. Now, the blood pressure tablets, again, it is focused on reducing or preventing protein in your urine. And there is a class of drugs called ACE inhibitors, or what we call an angiotensin receptor blockers, and which are the ones that should be your first line. And many of you diabetics, you will be on something with ending with pril, ramipril, lisinopril, captopril, enalapril, or something ending with a sartan, irbesartan, losartan, telmisartan, candesartan, various different drugs. So you need to be on either one of those as a first line to control blood pressure. So what about the diabetes itself? Now, this is where we've made huge strides in changing the paradigm, where if somebody develops diabetes and they develop kidney disease, we have changed the paradigm from planning for dialysis to trying to see whether we can prevent that ever happening. So I suppose the first drug that anybody with tablet who needs tablets should be on is metformin, and it's a very common, very well tolerated drug that's been there for decades, and we can give it until your kidney function is 30% or less. Until it hits 30%, you can, above 30%, you can have that medication, and you should be on it because it's one thing that helps to control blood diabetes, doesn't cause weight gain, because a lot of diabetic medications, including insulin, can cause weight gain, and this is very safe, well tolerated. Once the kidney function below 30%, it's a conversation for you to have with your GP, because the recommendation is you shouldn't be on it, as in some people that can increase the acid levels of lactic acid levels, which can be dangerous. But up to 30%, you should stay on metformin. Now, the class of drug that is made almost revolutionized the way we can manage diabetes and manage diabetic kidney disease and prevent, slow your kidney function getting worse over time, is a class of drugs called Sglt2 inhibitors. It's very hard to pronounce, Sglt2 inhibitors. So the drugs in that class are, they end with 4 or 5 letters called flozin, Flozin, 6 letters. So it can be a drug called dapagliflozin, empagliflozin, canagliflozin. They're the 3 commonest ones that are in the market. So that is widely seen, should be now the second diabetic medication you should go on. So if you go on metformin and if your blood sugar is still not well controlled, then the next one you should be talking to your doctor is to go on a flozin, because one, they work in helping your diabetes, but the other big impact of this class of drugs is that they slow the kidneys from getting damaged, right? So you start it early, then the chances are during your lifetime, you will avoid ever needing dialysis or transplantation, provided obviously your blood pressure is well controlled, you have a decent health and lifestyle. I'm not going to guarantee that you will not end up on dialysis or transplant, but it's a drug that has a huge positive impact. Now, the debate is there, and now, by and large, me as a kidney doctor, if I see somebody who has got signs of kidney damage or kidney disease as a result of diabetes, even if the diabetes is superbly well controlled, I will recommend the GP to start them on a flozin, canagliflozin, empagliflozin, because what we find is that even if the diabetes is well controlled, adding this medicine on top of what you have will help your kidneys and help to slow the kidney burning away. So that is essentially where I want to stop. Now, obviously nothing, as my mom and dad said, there's no such thing as a free lunch. as these medicines all have side effects. So SGLT2s are new. Now, the commonest side effect is people feel they need to pee a lot, and they feel thirsty a lot. And I think that initially happens, and then they get better, and those symptoms after a few days settle down. Now, if there are doctors in this, one thing we know is that when you start this medicine, your kidney function temporarily will drop, but then it gets better. And then actually on the longer time, it prevents the kidneys getting any further damage. So you need to be monitored. You need to take the medicine. You need to make sure you're well hydrated. You're drinking plenty of fluids, because obviously if you're making a lot of urine, you need to make sure that you need to drink plenty of fluids. I'm going to stop there because I'm already well beyond, because it is indeed a big topic. And when I saw the WhatsApp from Hanif saying it's 10 minutes, I sort of, I do talk fast, so that was good. And I'm now going to stop talking. And I do talk a lot as well, so I'm going to stop talking. There are questions
Thank
as
you
well
very
on the
much.
chat.
Thank you so much, Dr. Ravi. That's